This episode of the Nurse Practitioner Podcast is sponsored by Dakin's Wound Cleanser. When you're treating persistent, hard-to-heal, or complex wounds, you need a solution you can trust, like Dakin's Wound Cleanser. Just how powerful is it? Dakin's Wound Cleanser has been proven to kill even highly resistant bacteria like MRSA and VRE within only 30 seconds. It's non-cytotoxic, shelf-stable for 2 years, and more cost-effective than other wound cleanser brands. When you need a solution you can count on, ask for Dakin's. In this episode of the Nurse Practitioner Podcast, Dr. Alexander Wrynn discusses penicillin. Thanks for joining us today, Dr. Wrynn.
Oh, you're welcome. Thank you for having me.
So first, how do you define and categorize adverse drug reactions?
So I think that's a very important topic to talk about to start this talk off. With penicillin allergies and any drug reaction, it's important to know the difference between the two major categories of allergic reactions. The first category, you have adverse drug reactions. So this is any unexpected reaction that occurs from taking a medication. An example of this is you take a dose of amoxicillin to treat strep throat, and the amoxicillin makes you feel nauseated. It wasn't expected. The amoxicillin was expected to treat your infection. It wasn't expected to cause you to feel nauseated, though. So that is the definition of an adverse drug reaction, where the second category is a hypersensitivity reaction. So these are those adverse drug reactions, but they have an immunologic mediated cause. So an example of this is anaphylaxis. Hypersensitivity reactions can actually be further classified by using the Gell-Coombs classification system. So this looks at 4 different levels of hypersensitivity reactions. The type 1 reactions, which are IgE-mediated reactions, occur within an hour of taking the medication. The primary example of these is anaphylaxis. So somebody takes a medication that they're allergic to, and within 15 minutes, they go into anaphylactic shock. A type 2 hypersensitivity reaction is a cytotoxic reaction. This occurs hours to days after being exposed to the medication. Hemolytic anemia is the primary example for a type 2 cytotoxic reaction. Type 3 reactions are immunocomplex reactions that occur 1 to 3 weeks after exposure to the medication. The primary example for this is serum sickness. And then type 4 reactions are cell-mediated reactions. Type 4 reactions are actually categorized into 2 different categories. They're both cell-mediated reactions, but there are minor cell-mediated reactions. These occur days to weeks after being exposed to a medication. And these are simple drug rashes or contact dermatitises that you get from exposure to a medication, where severe cell-mediated reactions also occur days to weeks after. These are your scary drug reactions, your skin peeling drug eruptions like Stevens-Johnson syndrome or DRESS syndrome. These are your severe reactions that will land your patients in burn units or intensive care units or in the hospital in general. It's important to be able to categorize these because we'll later discuss how patients who have these severe cell-mediated reactions should not have future exposure to the offending agent.
Thanks for explaining the adverse drug reactions. What are the current statistics for penicillin allergies?
So penicillin allergies are very common in the United States. I think every nurse practitioner who's ever worked, or any clinician in general, has probably been exposed to a patient who's had a listed allergy to penicillin on their chart. Around 10% of the US population will report an allergy to penicillin. However, less than 1% of those are true IgE-mediated allergic reactions, meaning anaphylaxis, as I discussed earlier with hypersensitivity reactions. And even those with IgE-mediated reactions, around 80% of those individuals will lose or grow out of that reaction. Penicillin allergies in children are just as common. We really worry about them in children because childhood allergies will often become adulthood allergies. 6 to 10% of children in the United States will have a parent-reported drug allergy, meaning that their parent reports they have a drug allergy. And beta-lactams and penicillin antibiotics are the most commonly reported. Most of these reactions are minor dermatologic changes. It's those type 4 minor reactions, but these often occur in the setting of a viral illness. We all know the classic example of patients with mononucleosis being given errant doses of amoxicillin or augmentin and they break out into a rash. That's just a reaction between the virus and the medication. It's not a true allergic reaction. And 76% of drug allergies in children are low risk allergies as well.
Those are some eye-opening statistics. What is the risk of cross-reactivity between penicillin and other beta-lactams?
So beta-lactam antibiotics often get lumped together. They have a similar central ring. The families are your penicillin antibiotics, your cephalosporins, your monobactams, and carbapenems. Each of these antibiotics have a unique individual side chain. The side chain even differs between antibiotics in the same family. So penicillin and amoxicillin won't have the same side chain. A cefazolin won't have the same side chain as a ceftonir or ceftriaxone. And then the difference is even more broad when you compare group to group. We've always learned that common statistic that 10%, everybody has always said that there's a 10% chance risk that a patient with a penicillin allergy will have an allergic reaction to a cephalosporin. That has really been proven to be an overestimation. More recent literature has shown that this cross-reactivity rate is around 2%, with some suggesting it's even as low as less than 1%. Cross-reactivity is higher in individuals who have known severe reactions, but it's really dependent on each antibiotic's unique chemical side chain. So it's very important to use something like a side chain chart. You can find these online that compare the side chains between different antibiotics, because that will help you decide, is that antibiotic safe for that patient's reported allergy?
Thanks for sharing those drug-drug interactions. What risks do reported penicillin allergies pose for patients?
The penicillin allergies do come with a lot of risks. We think of them as relatively benign because everybody has one. I know there's a lot of joking and laughing, when we think about them, that, they're always not serious, but they do cause a lot of serious problems for patients. That typically broadly, the most concern is patients are exposed to unnecessary broad spectrum antibiotics when they can't be prescribed a penicillin. But reported use of these alternative agents can cause inadequate treatment, unnecessary adverse drug reactions. It can contribute to the rise of resistant pathogens and increase healthcare costs. There's several examples through literature. You can see patients who have failures in treatment for MSSA bacteremia when they have a reported penicillin allergy, which can lead to poor outcomes, including increased mortality rates at 90 days. There's been failures and delays in drug treatment in patients with septic shock. And then surgical prophylaxis, patients with reported penicillin allergies are 8 to 16 more times likely to receive an alternative therapy. And in those patients, some studies have shown that surgical site infections were increased by 50%.
We appreciate you sharing those risks. What are the best questions to ask patients about their reported penicillin allergies?
So I think the most important thing that nurse practitioners who are working in a primary care setting or working as like a hospitalist or in an emergency room or urgent care can do is just asking the right questions about the allergy. If you can get that far, I think that's the most important thing you can do to kind of dig into what is going on with this allergy. I think some of the most important things to ask are, what medication caused the reaction? And you want to be specific. You don't just want to say penicillins in general. Was it amoxicillin? Was it augmentin? Was it penicillin? Was it Zosyn? You want to know specifically what penicillin caused the reaction and what happened. What was the reaction? Did they break out into, if they say rash, was it hives? Was it itchy? Did it happen right away? You want to know, because you want to know how soon after taking the medication did this reaction occur. Because if you think back to those types of hypersensitivity reaction, if somebody breaks out into hives within 15 minutes of taking penicillin, that's more concerning for something like maybe an IgE mediated reaction than one of those delayed hypersensitivity cell mediated reactions. And then you want to know, when did this happen historically? Did it happen 5 weeks ago, 5 years ago, 15 years ago, in childhood? And then what antibiotics have they tolerated since this reaction occurred? This is probably the most telling question that you can ask a patient about their drug allergies. You would be surprised the number of patients who report an allergy to something like amoxicillin, but then tell you that they've taken Augmentin since. That means that they are highly unlikely allergic to amoxicillin, given the fact that one of the components of Augmentin is amoxicillin.
Thanks for sharing those allergy insights. How do you risk stratify a patient's reported penicillin allergy?
So with looking at risk, you take the questions that I just reviewed, asking what the drug was, when it occurred, how soon after taking the medication did it occur, and then you're able to categorize patients as either low, moderate, high, or severe risk. Those patients who are low risks are those with more non-allergic symptoms. So these are people who get GI upset, headaches, they have this reported family history of a drug allergy to penicillin, and they have a delayed onset reaction, like they got rash 5 days after taking the medication, but it wasn't something like a Stevens-Johnson syndrome or one of those other severe cutaneous reactions, and it occurred greater than 10 years ago. So anybody who has had these minor symptoms like nausea, headaches, minor reactions, or minor rash that occurred greater than 10 years ago, you would stratify as low risk. People who are moderate risk are those with non-severe reactions, but they seem a little less safe than those with lower risk reactions. These are people who get maybe one isolated patch of hives an hour or so after taking the medication. They itch, or they have a more IgE-like reaction, but it doesn't meet the definition of anaphylaxis, because the definition of anaphylaxis is an allergic reaction that occurs within an hour of taking a medication and affects 2 or more body symptoms. These patients have more rapid onset of their symptoms, and these reactions have occurred within the past few years. It's important to note that any pregnant patient or a patient who's critically ill should always be classified as moderate risk or above when you're thinking about challenging a drug allergy. Individuals who are high risk are those who have anaphylaxis or severe drug reaction that occurs within an hour of taking the medication, and they have 2 or more affected body systems. For example, they develop some tachycardia and shortness of breath, they have a diffuse rash, vomiting, or they have severe allergic symptoms and they're hypotensive. High-risk patients are also those with prior positive penicillin skin tests, those with recurrent drug reactions, meaning they had an allergy to penicillin, took penicillin again and did okay with penicillin, but then took it a third time and had another reaction, or those with multiple listed beta-lactam allergies. They're allergic to multiple cephalosporins or multiple penicillins. And those who are severe risk, or they should avoid future beta-lactam exposure, are those who have severe cutaneous reactions like Stevens-Johnson syndrome, those with cytotoxic or immunocomplex hypersensitivity reactions, or those who develop things like nephritis, hepatitis, or other signs of end organ damage. In the future, these patients should avoid any challenge or reattempts of beta-lactam therapy and be prescribed an alternative agent.
Thanks for detailing those classifications. Finally, what interventions are available for reported penicillin allergies?
So intervening penicillin allergies should be based on your level of comfort. There should also be safety considerations taken. Some of the things that I'm going to discuss in the next few minutes, like doing graded drug challenges and things, those should always be done with adequate staff or I should say adequate supportive staff present, and access to emergency medications in the event that the patient does have a true allergic reaction to the medication. So it really should be based on the safety of your office and your level of comfort. If the most you can do is just ask the patient the appropriate questions, risk stratify them, and offer them referral to an allergist for further testing, I think that's a great start. So in the primary care setting, you can treat patients with low risk reactions, those with nausea, GI upset, other minor reactions. These are the patients you can probably feel the safest about intervening on. They really just need counseling on adverse effects and action planning to prevent future symptoms. You want to be supportive, understanding, offer them, maybe if they have a lot of nausea, suggest taking the medication with food, maybe offering them a short course of Zofran to get them through the treatment course. Those with moderate risks, this is where it gets a little bit more challenging to manage in the primary care setting. These are a little more resource intensive. A lot of times it's recommended that you do a 2-step intervention, which involves doing skin testing for a penicillin allergy, which really can be done by any well-trained healthcare provider, but is often best to be done in an allergist's office. And then if their penicillin skin test is negative, you can do an amoxicillin challenge. There's 2 ways to do a drug challenge. You can do a direct challenge, which is just giving them a full dose of amoxicillin and monitoring the patient for an hour after they receive the medication to see if they have any adverse reaction to the medication. Or you can do what is a 2-step or graded challenge, where you give the patient a 10% dose of amoxicillin, monitor them for an hour. If they have no reaction, you give them the full dose of penicillin or amoxicillin and monitor them for an hour and document if they have no reaction. Again, if you're going to be doing a drug challenge like this, you do need to commit the patient to being in your office for an hour for monitoring, which I know in a lot of offices is probably not acceptable. And then you need to have access to emergency medications like IM epinephrine, albuterol, IM Benadryl in the event that the patient has a severe drug reaction. Those with severe or high-risk allergies should really just be referred to an allergist. They're not someone that you would probably be comfortable managing in the primary care setting. And those, again, who have had severe reactions like Stevens-Johnson syndrome, DRESS syndrome, have a cytotoxic or immunocomplex hypersensitivity reaction, they should avoid beta-lactams in the future and be prescribed an alternative agent.
Thanks so much for your time today, Dr. Wrynn.
Oh, you're very welcome.
You can find Dr. Wrynn's NCPD feature article, Penicillin Allergies, a Guide for NPs, on our website at tnpj.com. Thanks for listening, and until next time. For more great content from the Nurse Practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. Please leave us a 5-star review on iTunes and Spotify, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at The Nurse Practitioner Journal, and on Twitter at TNPJ_journal. Thanks for listening. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed on this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Please note that the hosts of the Nurse Practitioner Podcast are not clinicians. However, we created the Nurse Practitioner Podcast to bring you relevant clinical information by NPs for NPs. Thanks again for listening.